Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital. Welcome to Yale Cancer Answers with the director of the Yale Cancer Center, Dr. Eric Weiner. Yale Cancer Answers features conversations with oncologists and specialists who are on the forefront of the battle to fight cancer. This week, it's a conversation about the surgical treatment of thoracic cancers with Dr. Dan Boffa. Dr. Boffa is a professor of thoracic surgery at the Yale School of Medicine. Here's Dr. Weiner.
Maybe we can just start off, as I often do, just asking you a little bit about yourself. How was it that you became a doctor? And probably more importantly, how was it that you ended up focusing on cancers of the chest?
Well, I grew up in Ohio at a time when I was left to the television a fair bit, and
you and me both.
I was really drawn to the television show MASH, and more for the medical aspects and the dynamics than some of the mischief on that show. But that really drew me to surgery, and it was only later in life that I learned that Hawkeye, who was the character I most identified with, was on the show a thoracic surgeon. But that was not my draw to the specialty.
Wow. Okay.
But when I was in New York as a surgery resident, I had a mentor who really got me interested in thoracic surgery and the anatomy and just it's one of the few specialties where we really go in multiple different parts of the body and treat literally hundreds of different types of diseases. And so it allows you to be a physician as much as it does a surgeon. And I really like that.
Now, there are thoracic surgeons who spend less of their time focused on cancer than you do, correct?
Yeah. I think in the field of surgery, the lines get a little bit blurry, and it depends on the size of the hospital and the types and complexity of cases that come through. I grew up in an era where the thoracic surgeons really did cancer and non-cancer. And so I have continued to have that as part of my practice. But I would say the majority of thoracic surgeons spend the majority of their practice dealing with at least lung cancer. Some of the more less common cancers, I think a lot of the thoracic surgeons tend to refer those on to larger centers, such as Yale or some of the other larger centers.
And other than lung cancer, what other cancers do you end up treating?
Esophageal cancer is probably the second most common, but really any tumor that arises in the chest, and that could be tumors can arise from the bones, mesothelioma. There are tumors can spread from other parts of the body to the lungs, and we can help the teams that manage colorectal cancer, for instance, by treating some of the sites of disease that spread to the lungs. And in the abdomen, there are various cancers that we get involved with, sometimes gastric cancers, that will be close to the esophagus. But really anything that happens in the chest that doesn't need a heart surgeon, we're the people to call.
So maybe we can start off talking a little about lung cancer, and then we'll move on to talking about esophageal cancer. We recently had Roy Herbst on the show and talked about some of the medical aspects of lung cancer treatment and how it has just evolved so much over the past 20 years with both immunotherapy and various forms of targeted therapy. Tell us about your involvement in patients with lung cancer and in particular how the changes in the medical therapies have affected what you do.
So whenever we think about cancer, we think about what we see and what we can't see. So surgery is a treatment that's very effective in sites of cancer that we can see. Unfortunately, a lot of patients who have their life shortened by cancer, it's the disease we can't see that gets them into trouble. And I would say what's really exciting about the current era of cancer is we now have answers for the disease we can't see that we've never had before. And so we're turning more patients into curable than we've ever seen. And
to be clear, the not seeing, which is what the disease that ultimately can threaten someone's life, it's not seeing it at diagnosis, but eventually it becomes apparent.
That's right. So it's the microscopic cancer that's either living in the blood or a vital organ that has left the cancer where it started and traveled somewhere else. And it's just too small to be seen on a CT scan or a PET scan or a brain MRI. And it's only over time that that cancer grows and then becomes apparent on the scans. But at that point, our ability to treat it for a cure historically or in the past has been very low. But now with some of these treatments, and lung cancer in particular, we're taking patients who have always been thought to be incurable and actually curing them. And so it's just a really exciting time.
Yeah, no, for sure. And while ultimately, maybe there'll be a time when there's the magic pill for all cancer. At the moment, as the pills and as the infusions get better, it just allows us to do that much more in the way of surgery because, as you said, people who in the past wouldn't have been curable, now we can eradicate their micrometastatic disease, and that leaves you dealing with the lung nodule that's still left behind.
Absolutely. And I think at the same time that the treatments, the chemotherapies and the medications that are given intravenously have improved, the surgical techniques have gotten a lot better. And so we used to make a 5 to 10 inch incision to remove early stage lung cancers. And now 90% to 95% of lung cancers are removed using minimally invasive techniques. Here, mostly using the robot. So your biggest incision is about 1.5 inches, maybe 2 inches, and everything's done minimally invasively. And that really speeds up recovery and allows people who maybe weren't as healthy to get through an operation a lot more easily and get back to their life much faster.
And those 10 to 15 inch incisions for early stage lung cancer, that was being done how long ago? 20 years? 10 years? How long's it been?
I would say a 10 inch incision is something I've seen maybe 25 years ago. Even when I have to do what we call a traditional incision, it's now like a 5 inch incision, and we don't usually cut big muscles. So if somebody ever says you're not a candidate for a minimally invasive approach, that still is way better than what patients used to be subjected to 25, 30 years ago, where it was a much bigger cut and ribs were commonly taken. Now, the vast majority of patients who even get a traditional incision, the recovery is actually much faster than when we were making those really big incisions.
No, I think it's really remarkable. It's been true across the whole surgical field. I'll share that, I recently had a hip done, and, the day of surgery, they try to get you up walking. There was a time years ago when, whether it was a hip or whether it was a lung cancer, people were put in their beds for, a long time.
Well, I think that medicine tends to improve in one area and pull other areas along. And so I would say that the patient experience now benefits from better anesthesia. So people are less nauseous, people wake up faster, their pain is much better controlled. At the same time, we're making smaller incisions, we're better at controlling pain. And because of the opioid pandemic, we really try to minimize narcotics, and we have all of these different techniques that we can keep people active and doing the things we need them to do to recover, yet doing it in a way that their pain is controlled and they're not getting a lot of narcotic medication.
Yeah, I mean, it is fairly dramatic how the concern about opioids and the abuse of opioids has led to far more creativity about how we use them in people who have significant pain, and how we don't let people remain in pain, but we come up with other ways of approaching the pain. So, I'm not sure I've ever asked anyone this question, but, I'm sure occasionally when you're doing a bigger surgery, you're in the operating room for quite a number of hours. What's that like to be just standing over a patient and it is standing, it's not sitting most of the time. How do you get through all that?
It is amazingly compelling when you are in charge of a patient's life, and not just whether something big happens in the operating room, but when somebody trusts you to take them to the operating room, they're trusting you to fight that battle for them. And so you are looking for any site of disease. You are so focused on getting every part of that tumor out as cleanly as possible. And it really commands your attention so much that the time really flies by. I do a lot of surgeries that are 3 hours, but I do a lot of surgeries that are 7 hours. And it really, I would consider myself to have a pretty short attention span outside of the OR. But when you're in the OR, that responsibility is so compelling that the time just absolutely flies by.
Well, I'm not a surgeon, and I have never been in a 7-hour operation in the OR. I can tell you that the times when I feel most centered and focused are when I'm in a room with a patient, and in fact, the door closes and nothing else in the world is happening for me. I would hope that I would have the attention to do that for 7 hours, but you obviously do.
Yeah, and I was a carpenter before medical school, and it is when you're in the thick of things, it's problem solving, and it just, when you're concentrating on something that is stimulating and you care a lot about, time just flies by.
Yeah, no, and I suppose when you saw that in medical school, that's one of the things that drew you to become a surgeon.
100%.
Yeah. Well, we're going to need to take just a brief break. When we come back, we're going to talk about esophageal cancer and what has evolved in that area. And we'll talk a little bit about lung cancer screening.
Funding for Yale Cancer Answers comes from Smilow Cancer Hospital, where their hematology program offers comprehensive diagnosis and treatment of blood cancers, including lymphoma, leukemia, and myeloma. SmiloCancerHospital.org. There are many obstacles to face when quitting smoking, as smoking involves the potent drug nicotine. Quitting smoking is a very important lifestyle change, especially for patients undergoing cancer treatment, as it's been shown to positively impact response to treatments, decrease the likelihood that patients will develop second malignancies, and increase rates of survival. Tobacco treatment programs are currently being offered at federally designated comprehensive cancer centers, such as Yale Cancer Center and at Smilow Cancer Hospital. All treatment components are evidence-based, and patients are treated with FDA-approved first-line medications, as well as smoking cessation counseling that stresses appropriate coping skills. More information is available at yalecancercenter.org. You're listening to Connecticut Public Radio.
Good evening again. This is Eric Weiner with Yale Cancer Answers. And I'm joined tonight by Dan Boffa, who is a thoracic surgeon and leads our division of thoracic surgery. Dan, let's shift gears a little bit. We talked about lung cancer and we talked about surgical techniques a bit. Let's talk about esophageal cancer. And esophageal cancer, I think, is one of those cancers that people are pretty frightened of. And while it's not the most common cancer, it's by no means uncommon. So tell us a little bit about esophageal cancer.
So esophageal cancer is a dangerous cancer that we don't have a great way to screen for yet. And I think because of that, we're not finding it until people have symptoms. And once you have symptoms, it is not necessarily spread to vital organs, but it is not typically at its earliest stage and not the point where we're best able to cure people. So
can you just comment for a minute on those symptoms?
So if you notice that you're having difficulty swallowing, that food is getting stuck, particularly in the mid to lower part of your chest, even if it just happens more than once, you really need to let your primary know about it and see a gastroenterologist. A lot of us have heartburn, and that's one of the things that makes esophageal cancer difficult to identify, because the way that screening works is to find dangerous things before they do dangerous things. And the symptoms and the people at risk for esophageal cancer are generally people who have heartburn, who are over the age of 50, who are overweight. White males tend to have a higher risk. Well, that's a lot of us. And I've described this in the past as kind of like a tornado. So tornadoes often happen when the conditions are right for a tornado, but most of the time that conditions are favorable for tornadoes, you don't get any. And sometimes tornadoes happen when the conditions aren't favorable. So it's really hard to pin down who you would do upper endoscopies instead of a colonoscopy, which goes from the bottom. This is an upper endoscopy, which goes from your mouth into your esophagus. And so it's hard to screen for. And so we miss that opportunity to find it at its earliest stage. But if you do have heartburn and it's not well controlled with an over-the-counter medication, I think and you're over the age of 50, I would talk to your primary about having an upper endoscopy.
And then there are certain conditions that are associated with a higher risk of esophageal cancer, things like Barrett's esophagus.
Yeah, so Barrett's esophagus is a change in the esophagus where the lining changes from its normal lining to the lining that the intestine has on the other side of the stomach. In a lot of ways, that makes sense because the downstream side of the stomach sees acid all the time. And so its lining is designed to protect it, whereas acid shouldn't be going backwards. And so that lining is designed to help things pass through it. And so Barrett's esophagus sounds like a good thing because the acid is turning the lining into something that should be protecting it. The problem is once it makes that change, it loses its ability to control what it does and what it looks like. And a series of changes can happen and it can turn into a cancer. But again, most Barrett's does not turn into cancer. So it's, again, hard to nail down who is really at highest risk.
And what about the role of tobacco use and alcohol in esophageal cancer?
Both have been associated with an increased risk of esophageal cancer. So I think there's a lot of people associate tobacco use with lung cancer, but really most or many cancers have an association with tobacco use. And we're increasingly finding signals that moderate to heavy alcohol use increases to some degree your risk for cancer in multiple parts of the body, including the esophagus and stomach.
And with esophageal cancer, my recollection is that if you think of smoking and drinking as one each, that 1 + 1 doesn't equal 2, it equals 3.
Yeah, I think that like in many cancers, risk factors tend to stack into a greater risk. I commonly describe risk factors as like smoking is a bad thing, choosing to swim in gasoline is a bad thing, doing both of them is a really, really bad thing. And so I think that's a fair point.
I think that describes it quite well. So how has esophageal cancer treatment changed over the years? Because this is one of those tumors where our success rate is going up.
So the mainstay of cure for esophageal cancer has been removing the esophagus and reconstructing the esophagus, typically by bringing the stomach, making it into a tube, and replacing the esophagus. So several things have happened. One is the earliest stage esophageal cancers can now be treated successfully endoscopically. So you come and go the same day, you have an upper endoscopy, and either by cooking with heat or freezing or scraping, you can remove the earliest stage esophageal cancers, which we used to do an esophagectomy for. Now, for the people we do offer an esophagectomy for, it is a much less invasive operation. The 90% of the esophagectomies I do now are done with a minimally invasive approach, and the biggest incision, which used to be 2 8-inch incisions, is now the biggest incision is a single 2-inch incision. And so the recovery is much faster and people get back to their routines much faster. So, and now, just like in lung cancer, there are different types of chemotherapies and immunotherapies that are starting to show promise in esophageal cancer. So again, trying to address the cancer we can't see on CT scans and PET scans, the microscopic cancer, using the novel treatments is showing great promise in esophageal cancer as well.
And immunotherapy, presumably with chemotherapy, is now a standard for many patients with esophageal cancer.
For many patients, not all, but for many patients, I think because there's less of them than say lung cancer, we're still trying to learn who would be best served by immunotherapy and some of the more novel treatments.
And what are the kinds of problems people with esophageal cancer have after surgery? Well,
if you have your esophagus removed and reconstructed, the biggest thing is everybody walks around with about a Coke can's worth of fluid in your stomach, which is now in your chest as opposed to your belly. And so that means that you can't lie flat. Now we have people that are competitive triathletes, people who swim, and I have a woman who bikes in Europe. Actually, we have a lot of bikers. So you can get back to a very normal quality of life, but there are some considerations for sure.
And so do people have to sleep on an incline?
Yeah. So you have to sleep with your head of the bed 30 degrees, either with a wedge or a mechanical bed.
And if not, the problem is that there's aspiration of fluid into your lungs.
Yeah, there's no valve anymore that separates the stomach from the esophagus. So if you were to lie completely flat, that Coke can's worth of fluid that could go into the back of your mouth and you could choke on it. And so it's really an important thing that you keep your head of bed elevated at all times.
This sounds like a challenge for biomedical engineers.
Well, I think there's a lot of opportunities for innovation, and I think that I think both in the engineering world, but also in sort of the data science world to try to figure out who are the best people for which treatment.
Sure. Can we talk a little bit about lung cancer screening? I had promised to do that on a previous episode or previous show, and we didn't quite get into all the details that I had hoped to. But lung cancer screening is potentially really life-saving, potentially very important.
Yeah. So lung cancer screening in my lifetime will probably be the single most impactful medical discovery for the cancers I treat. Lung cancer screening reduces a person's chances of dying of lung cancer by more than 20%. It's a CT scan that happens once a year and looks for anything that could be a precancer or a cancer, and then leads to the various evaluations. For reasons that we don't fully understand, only about 10% of the people who are eligible for screening, so those are people who are 50 years or older and who've smoked, only about 10% of the people who are eligible actually participate. We've tried to understand why this is, and we've done some research here at Yale. One of the things we found that was a bit surprising is that the primary care clinician is pretty important in the lung cancer screening process. And 1 out of 3 people in the United States does not actually have a primary care clinician. We tried to call hospitals to see if they could help, and actually only 10% of the hospitals can actually help if you call them directly. And so we're working with with big organizations and primary care clinicians to try to alleviate that barrier to screening. But I also think patients have legitimate concerns about screening. I think a lot of people feel that there's no hope if you find things. Nobody wants to look for something you don't want to find. But I think that when you participate in screening, you're going to find a cancer at its earliest stage when the treatment is a lot easier on you. And so I do think that it's such an important thing. And anybody who's listening to this, if you know somebody who's 50 years or older and has a history of smoking, either have them reach out to their primary or call us at Yale, and we can hook you up with screening.
And do you think some primary care doctors just don't buy into it yet?
There was a recent study. I've had conversations with leaders of the primary care organizations, and there's just such a shortage of primary care clinicians right now that if you had a primary care clinician do everything that's recommended as a best practice, they would have to work 8 or 9 days a week, which is obviously impossible. So I think that a lot of the primaries trust that the screening works. It's just they're so overwhelmed in many parts of the country, they just don't have the bandwidth to chase down all of these things. So I do think it's a responsibility that we have to put on patients as well as their primaries, because it's so powerful and such an important thing to do.
Dr. Dan Boffa is a professor of thoracic surgery at the Yale School of Medicine. If you have questions, the address is canceranswers@yale.edu, and past editions of the program are available in audio and written form at yalecancercenter.org. We hope you'll join us next time to learn more about the fight against cancer. Funding for Yale Cancer Answers is provided by Smilow Cancer Hospital.